Hi, and welcome to our symposium on addressing key targets in advanced non-small cell lung cancer. Today we will cover the latest data on HER2, HER3, and TROP2 targeted therapies. I'm Jänne from the Dana-Farber Cancer Institute in Boston, Massachusetts, and I'm joined by my two esteemed colleagues, Dr. Edward Garon from UCLA and Dr. Helena Yu from Memorial Sloan Kettering in New York. I wanted to thank Peer Review for providing this educational session, AstraZeneca and Daiichi Sankyo for providing the educational grants for this symposium. Please take part in the audience polls that will be posted to you throughout the webcast. You can also submit any questions you have throughout the program. And on the following slides, we will review all the relevant disclosures. Please also visit us on web at peerreview.com/ADC2022. View the slides and practice aids now and download them after the event. Okay, this is our agenda today. We will have three different presentations focusing on the three different targets, HER2, HER3, and TROP2, as well as some discussion towards the end and case presentations. Now, I'll first start with an introduction on current gaps and opportunities for improvement on expanding and understanding molecular complexity of non-small cell lung cancer. We have all come to appreciate the pie chart in non-small cell lung cancer. Lung adenocarcinoma is a disease made up of specific subsets of the disease, whereby there are multiple approved drugs shown here on the right-hand side for the different subsets of disease. And in fact, there are 9 different subsets where we have specific drug approvals. And hence, it's important to be able to identify for our patients, does their cancer harbor one of these genomic alterations for us to effectively treat them with targeted therapies. Now, when you look at the fraction of individuals who actually get tested, it's not as high as one would envision. On the top left from the My Lung Consortium, you can see that although the vast majority of individuals are tested for EGFR mutations and ALK rearrangements, when you start to go down and ask what fraction of individuals are tested for all 5 of these biomarkers, or what fraction of individuals get next generation sequencing, it is still not the it is not the majority of individuals. On the left-hand side, data from Flatiron, looking at also patients of different ethnic backgrounds with lower rates of testing for patients that are African American, whether they have non-small cell overall or just non-squamous cell non-small cell lung cancer, hence suggesting that we need to do better as a community to test our individuals, for our patients, for individual genomic alterations. Despite the rapid advances of targeted therapies for non-small cell lung cancer, we still need new and novel therapies. As I showed you on the pie chart, we have multiple approved therapies. However, not all of our therapies are effective or effective for very long periods of time. And even the most effective therapies, patients do develop resistance, and we need new targeted therapies. In addition, there are subsets of that pie chart where we do not currently have any approved therapies. One example being HER2 mutations, which make up a few percent of non-small cell lung cancer, but at the current time do not have an approved targeted therapy. Now, our symposium will focus on antibody-drug conjugates, and this is a class of drugs that is relatively new to the thoracic oncology field. And antibody-drug conjugates are antibodies that are conjugated through a linker to a cytotoxic payload. And these bind a protein, a cell surface protein, are then internalized into the cells, and the payload is released in the cells. And this is a schematic representation of that for HER2 targeting ADC. You can see on the left-hand side, you have a HER2 positive cancer cell, HER2 antibody drug conjugate binds the receptor, it is internalized, then the receptor and the payload end up in the lysosome where the payload is released, and it can be released into the cell where the antibody bound, or it can also leak out into adjacent cells that are potentially, in this example, HER2 negative, and be effective in that manner as well. And this is an example of that from a publication a few years ago, where the investigators mixed HER2 positive and HER2 negative cells and treated these tumors, and were able to show not only an effect in the HER2 positive cells, but also in the HER2 negative cells because of this effect of leaking into the adjacent cells that may not have the presence of the antigen for which the antibody binds to. Okay, so let's move on to the specific topics. I will speak on HER2 mutant lung cancer as the first topic. As I mentioned, HER2 mutations happen in about 3 to 4% of lung adenocarcinoma, and although there's a wide variety of HER2 mutations, the vast majority of them are exon 20 insertion mutations in one particular location, shown as a blue piece of the pie chart. There are multiple other mutations, but the exon 20 insertion mutation is by far the most common. Now, I mentioned there are no approved targeted therapies for HER2 mutant lung cancer, but there are plenty of therapies that have been tried. And these can include antibodies that are single epitope antibodies, such as pertuzumab. These can include bispecific antibodies, can include antibody drug conjugates that I mentioned, or small molecule inhibitors, tyrosine kinase inhibitors, which are HER2 specific, for example, lapatinib, neratinib, or tucatinib, which have also been tested in this disease. But let's focus on the antibody drug conjugates for today. The first of these that was tested is TDM1, or adotrastuzumab emtansine. This was tested in a trial that was published by Dr. Lee a few years ago in the JCO, where HER2 mutant patients were examined. You can see on the right-hand side the waterfall plot and the Kaplan-Meier curve for PFS. There's about a 40% or so response rate in this patient population, with a progression-free survival of about 5.5 months. Now, trastuzumab deruxtecan is a next-generation HER2 antibody drug conjugate. It's extensively been tested in breast and gastric cancer and has approvals in those situations. And unlike TDM1, it has two differences. It has a different linker and has a different payload. And the payload here is a exatecan, or a topoisomerase inhibitor derivative. And this molecule has a high drug-to-antibody ratio of about 8 molecules per specific antibody, the goal being that it would deliver a very potent effect in each of the cells. And in lung cancer, this has been tested in two cohorts, one in HER2 mutant lung cancer and two in HER2 overexpressing lung cancer as part of this DESTINY-01 lung cancer study. And I'll first discuss the data in the HER2 mutant cohort that was presented at ESMO this last fall and was recently published in the New England Journal by Dr. Lee. And this trial evaluated 91 patients with HER2 mutant lung cancer. The ethnic distribution is shown there, as well as the region of the world where the patients were enrolled. Vast majority of individuals had kinase domain mutations, which being the insertion mutation. Asymptomatic CNS metastases was present in about a third of individuals, and smoking status, the majority of individuals were never smokers, as you'd expect for this patient population. This is the history of prior systemic therapies. The prior lines of treatment was 2 with a range of 0 to 7. The vast majority of individuals had received platinum-based chemotherapy. They may have also received anti-PD-L1 or PD-1 therapies, docetaxel, and the minority of individuals had had prior HER2 TKIs. Of note, you could not have had a HER2-directed antibody as an enrollment criteria for this trial. This is the response rate in the 91 patients. The response rate was 55%. The 50 patients responded. The vast majority of responses were partial responses. This is the waterfall plot. Now, the waterfall plot is color-coded for kinase domain mutations in blue and in orange for extracellular domain mutations. You can see, again, the vast majority of individuals had kinase domain mutations, although there are patients responding who have extracellular domain mutations as well. In the middle part are the biomarkers from the study, including the mutations, HER2 copy number, as well as HER2 expression. And what's interesting here is HER2 expression in many of these individuals is in fact 0. Now, this is 0 by breast cancer IHC criteria. Of course, it can't be 0 because the antibody is binding, but it suggests that the mutation is the more important biomarker here as opposed to the expression. Only a few patients had concomitant HER2 amplification. Both of them responded in this scenario. And on the bottom is the spider plot for this patient population. These are the PFS and OS curves. The PFS is about 8.2 months and the OS about 17.8 months. Now, this is the safety summary. It was generally consistent with the prior studies. Grade 3 and higher drug-related AEs occurred in about 46% of patients. Neutropenia was common. And one class of toxicities that is seen with this group of agents is interstitial lung disease, and it occurred in 26% of patients and resulted in death in 2 individuals. Now, I mentioned trastuzumab deruxtecan has also been tested in HER2 IHC positive patients. So these are the characteristics of those patients. A smaller study of 49 individuals broken down by IHC 2+ and 3+. On the right-hand side is shown the genotype distribution for these individuals. Some of them have targetable alterations, although for the vast majority of patients, we do not, in fact, know their genotype. Most patients had platinum-based chemotherapy as well as immune checkpoint therapy. The activity is shown here on the waterfall plot on the right, as well as the response rate. So the confirmed overall response rate overall is about 25%. It's 25% in the IHC 2+ and 20% in the IHC 3+ patient population. And again, mostly all partial responses essentially. Median duration of response is about 6 months. PFS in this patient population, 5.4 months with a median OS of 11.3 months. Now, this also lists the side effects from this, and again, similar to the prior mention of ILD in this patient population. So again, this is a side effect or toxicity of interest. So to summarize, trastuzumab deruxtecan showed durable anti-cancer activity in patients with previously treated HER2 mutant non-small cell lung cancer. In fact, it's received FDA's breakthrough designation for this patient population. There's preliminary anti-tumor activity in HER2 overexpressing non-small cell lung cancer. However, clearly the activity is less in this patient population than in the HER2 mutant patient population. And as I mentioned, ILD is one of the side effects that we need to watch out for. There is a plan to move and to study this agent in other instances in the second-line setting and also in the front-line setting, both in the HER2 overexpressing patients as well as the HER2 mutant patients. This is the study schema for DESTINY-Lung04 for trastuzumab deruxtecan in the HER2 mutant patient population. Patient are randomized to trastuzumab deruxtecan or to chemotherapy plus pembrolizumab, with the primary endpoint being progression-free survival. So this is an ongoing study. So I will now turn it over to my colleague, Dr. Helena Yu, to discuss HER3.
Great, thanks, Pasi. All right, so HER3 is another unique member of the HER family, and I think it's particularly unique because it has limited intrinsic kinase activity. It actually signals exclusively through heterodimerization with its other family members, and in particular EGFR and HER2. HER3 is activated by ligand binding specifically by neuregulin, and HER3 overexpression is actually pretty commonly seen in different solid tumors, including lung, colorectal, and breast cancer. And actual genomic mutations are much more rare, but we do see ERBB HER3 mutations as well as amplifications at low frequency in certain cancers. HER3 is expressed in the vast majority of non-small cell lung cancers. HER3 overexpression is associated with both metastatic progression as well as decreased relapse-free survival. A point to make here is that there is clear overlap between genomic drivers and protein overexpression, i.e. patients that have EGFR mutant lung cancer can also have overexpression of HER3. HER3 is overexpressed in EGFR mutant lung cancers, but actual HER3 genomic alterations are not seen as a mechanism of resistance to EGFR TKI. And I think important to note also that targeting HER3 may be relevant across multiple genomic mechanisms of resistance to EGFR TKI. So EGFR TKIs are the first-line treatment of choice for patients with EGFR mutant lung cancer, but of course resistance to therapy is universal. Mechanisms of resistance depend on the specific EGFR TKI utilized and also line of therapy. And you can see that on the figure on the bottom, where with earlier generation EGFR TKIs, of course, we saw emergence of T790M. And even with osimertinib, when we treated patients with osimertinib in the later line setting, there was a different spectrum of resistance mutations compared to first-line osimertinib, where actually in the majority of patients, we do not detect an acquired genomic alteration. And more commonly, we have been seeing off-target resistance mechanisms as well as histologic transformation. Platinum-based chemotherapies following EGFR TKI failure do have modest efficacy, but certainly are utilized in the second-line setting. And salvage therapies after TKIs and after platinum-based chemotherapy really have more minimal efficacy, and new treatments are certainly needed in this space. As Pasi mentioned with HER2, there are different HER3 targeted treatment strategies. Up kind of historically, we really have focused on monoclonal antibodies, so the naked antibody. And those have been looked at in unselected populations as well as selected populations like EGFR mutant lung cancers, and really have not seen success. And again, more present day focus is on antibody drug conjugates as well as some bispecific antibodies. So similar to, you'll notice similarities between this HER3 ADC and the HER2 ADC that was previously discussed. It consists of a naked anti-HER3 antibody that is linked to a chemotherapy payload, which is an exatecan derivative. So HER3-DXd was studied in a phase 1 study, specifically in patients with metastatic EGFR mutant lung cancer with progression on prior EGFR TKI treatment. The dose escalation portion assessed escalating doses of HER3-DXd, and then the expansion really focused on the dose of 5.6 milligrams per kilogram and focused on the patient population of patients that received prior EGFR TKI as well as prior platinum-based chemotherapy. Baseline characteristics are described in the bottom left of the figure. Of course, all patients received prior EGFR TKI. The majority received prior osimertinib. The majority also received prior platinum-based chemotherapy, and about half received prior immunotherapy. And I think important to highlight that this phase 1 population was heavily pretreated with a median of 4 lines of prior systemic therapy. So in terms of efficacy, the confirmed overall response rate in the population at large was 39%. Disease control was obtained for the majority of patients. Time to response was short, less than 3 months, and then the median progression-free survival was 8.2 months. So here's the waterfall plot that shows the percent shrinkage of target lesions for patients on the phase 1 study. It's hard to read, but I want you to focus on the bottom half of the figure, which shows or highlights 2 points. One, that this drug was active in a variety of EGFR activating sensitizing mutations, including exon 18 alterations. And then you can see that there are a diverse array of mechanisms of resistance to EGFR TKI that were seen in patients treated on study, including on-target mechanisms of resistance like C797S, and off-target resistance such as HER2 amplification and BRAF alterations. So here's the swimmer's plot of patients treated on study. You can see at this point, the majority of patients on study were still ongoing in regards to treatment. And then I think the other thing to highlight here is that in regards to progression, the majority of patients actually had systemic disease progression, and the minority had CNS progression that caused them to come off study. This, I think, is an important slide. I think patients on study were not required to be tested up front for HER3 expression, but all patients were required to have available tissue for retrospective HER3 expression analysis. The figure on the bottom left shows that all patients had some degree of HER3 expression, and then the middle figure shows really that there was no correlation between degree of HER3 expression and time since last EGFR TKI treatment. And then the figure on the bottom right is important because it shows that actually responses were observed in patients with a wide range of baseline HER3 H scores, really suggesting that degree of HER3 expression is not a great biomarker for response to pat-deruxtecan. In regards to toxicity, all patients did have some degree of treatment emergent toxicities. You can see the treatment emergent grade 3 or greater toxicities that were seen with some frequency on the figure on the right. We saw thrombocytopenia, neutropenia, anemia, fatigue, And I think it's important to highlight that these ADCs are chemotherapy. And so we do see the cytopenias that, of course, are common with chemotherapy. And then in terms of AEs of special interest, you can see on the bottom of the table ILD. The frequency of ILD with patritumab deruxtecan was somewhat lower at 5%, but again, this is a class effect seen in all of these ADCs. So in summary, with HER3-DXd, there was clinically meaningful durable efficacy with an overall response rate of 39%, a median PFS of 8.2 months. Efficacy was shown across different EGFR TKI resistance mechanisms in a difficult to treat population with no currently approved available targeted therapies. Anti-tumor activity was observed across a wide range of baseline HER3 expression. The drug patritumab deruxtecan is tolerable with an acceptable safety profile. There was a low rate of treatment discontinuation due to adverse events and a low rate of treatment-related interstitial lung disease. This is the current and future clinical development of HER3-DXd. The confirmatory phase 2 study is the HERTHENA study, which I'll show you a study schema for. And then the other important study to note is this agent is being looked at in combination with osimertinib as second-line therapy immediately following first-line osimertinib progression. And here's the study schema for HERTHENA, which is taking patients with metastatic EGFR mutant lung cancer, focusing on the common EGFR mutations exon 19 deletion and L858R. Patients have to have received prior osimertinib as well as prior platinum-based chemotherapy. And they are two things are being assessed, both a fixed dose of HER3-DXd as well as an up titration. And now I'll turn it to Eddie, for talk about discussion on TROP2.
Thank you, Helena. So I will now move on to speaking about TROP2. TROP2 is now basically a target of therapy that people have become familiar with. It's a transmembrane glycoprotein highly expressed in non-small cell lung cancer, but also other solid tumors. So this is not an exclusive story related to lung cancer. There clearly has been an association with higher TROP2 levels and poor prognosis. You can see in the upper right here data related to probability of survival in adenocarcinoma cases. But right now we don't really have established sort of TROP2 levels that are considered to be relevant for clinical care. In many respects, one of the reasons that people are familiar with this is sacituzumab govitecan, which is now an approved agent. This, of course, is not approved for lung cancer. It is approved for other malignancies. Lung cancer data is fairly sparse for this agent, which is a TROP2 antibody drug conjugate. In 2017, there was a report in the Journal of Clinical Oncology. Rebecca Heist was the first author, showing a response rate for all patients a little below 20%. Duration of response for all the patients was about 6 months. Down in the lower left, you can see the waterfall plot showing evidence of benefit, as well as a spider plot in the middle. You can see that the linker is a little bit different for this agent than what has been shown by the two prior speakers, as this is of course a slightly different payload, although there certainly are similarities with the payload. Again, we don't have a lot of data. As you can see, this was a small study, 54 patients originally. And nonetheless, though, we do now have 2 studies that are actually ongoing that are evaluating this. One is looking in the frontline setting with some therapies that include immune checkpoint inhibitors, and there is also a randomized study looking at a comparison with single agent docetaxel. So then there is a similar TROP2 targeting antibody drug conjugate to the molecules that were just described by Pasi and Helena. And this is datopotamab deruxtecan, which is also called Dato-DXd. It is, again, this same sort of a cleavable tetrapeptide-based linker, as well as the topoisomerase 1 inhibitor payload. Antibody-drug ratio is about 4 here. And this has been extensively studied now in lung cancer. I'm going to show you some of the data. This was a reasonably large study. One thing that is unique about TROP2 as a marker as compared to what you've heard about before is that this is looking sort of across lung cancer, not necessarily a specifically molecularly defined subgroup. And in fact, similar to what was described in the prior two presentations, although data for immunohistochemistry for the target was obtained as part of this study, it was not a requirement for enrollment. And to date, at least for TROP2, it has been difficult to correlate outcome with TROP2 expression. In some respects, this makes it hard when you discuss these agents with patients, because you explain that the goal is to direct the chemotherapy to where you see to cells that express the target. But then you tell them that whether or not they express the target doesn't really matter. So it can sometimes lead to mixed messages. But of course, the most important thing is assessing whether or not the agent helps in the management of their disease. The inclusion criteria, it was adults with good performance status, measurable disease. Patients with stable treated brain metastases were allowed. There was initially a dose escalation phase. But what I'm going to be addressing here is data on the dose expansion. There were 3 doses that were expanded: 4 milligrams per kilogram, 6 milligrams per kilogram, and 8 milligrams per kilogram. And we were certainly looking to establish tolerability, safety, and choose the appropriate dose, but also, of course, looking for efficacy as well. So here you can see the data with respect to toxicity. You can see that overall the agent was well managed. You can see the toxicity profile. As was pointed out, these are chemotherapies, so many of the toxicities that you see on the right, nausea, alopecia, are things that are typically associated with chemotherapy. There was a trend towards increase in the toxicity data with the 8 milligrams per kilogram. And as was mentioned with trastuzumab deruxtecan, there was an issue with ILD, and there were 3 patients with a grade 5 related ILD. All 3 of these patients were at the 8 milligram per kilogram dose level, and that dose level has subsequently been discontinued. It is no longer being evaluated as part of the program. So now with respect to efficacy, the efficacy was quite good. This was a heavily previously treated patient population. Most people had had at least 3 lines of prior therapy, and many of the patients had had significantly more than that. You can see the response rate data. All 3 of the doses with response rates in the mid to high 20% range. Again, this is in a heavily previously treated patient population. There were also many patients who did have stable disease as well. You can see the duration of response data here, which is quite good, at 6 milligrams per kilogram, which is the dose that is currently being further developed. You can see the duration of response of 10.5 months. And I think also somewhat reassuringly, there is a dose level that is a step down from the dose level that is currently being evaluated, this 4 milligram per kilogram dose level, that clearly has very significant activity that I think would be reassuring to people about that dose level should there be a need to dose reduce. On the right, you can see the waterfall plot showing clear activity of the drug. You can see that the 4 milligram dose is in green, blue for the 6 milligram per kilogram dose, and sort of a purple for the 8 milligram per kilogram dose. And what you can see is that there's no clear association on the waterfall plot with the dose. The spider plot on the bottom shows kinetics that would be anticipated with a drug of this class. So as I mentioned, one thing that is unique about the development of the TROP2 antibody as opposed to the prior antibody drug conjugates is that this was looking across lung cancer, and the study included both patients who did and did not have actionable genomic alterations. Of the patients who were enrolled on the study, again at the dose expansion, it was it was 180 patients. You can see that 34 of them had actionable genomic alterations. The treatment that those patients had received was quite similar to the treatments that had been received in other cohorts. The only thing of note being that based on a perceived lack of benefit with immunotherapy among these actionable genomic alteration patients as compared to the total patient population, immunotherapy was used less frequently as a prior therapy. What you can see is that for the most part, this is a study of patients who had EGFR mutations, as would be expected based on what the actionable genomic alterations that were assessed were. There were 3 patients who were evaluated who had an ALK gene fusion, as well as 1 each with ROS1 and RET gene rearrangements. You can see the dose distribution with a little bit of a skew towards the 8 milligram per kilogram dose level. And what you can see is that the duration on study was reasonably long. Here you can see the response rate. The response rate was 35% in this group. It is a little bit small to see on the bottom, and I realize a busy slide when you look at the waterfall plot. But again, most of these patients had EGFR mutations. You can see the ALK gene rearranged patients were in green here, and you can see the others also in different colors. You can see that the mechanism of resistance differed particularly amongst the EGFR mutation positive patients, with many patients having, for instance, T790M mutations, many of them not. No clear trends across the waterfall plot indicating that across multiple different genomic alterations, as well as across multiple different resistance mechanisms, that there was evidence of activity of this agent. And so activity again noted in patients both with and without actionable genomic alterations. So in summary, the agent has clearly shown encouraging anti-tumor activity at multiple dose levels, and the 6 milligram per kilogram dose is being selected for further development. Response rate was 28% with a duration of response at 10.5 months in that population. The toxicity was generally well tolerated, although there were these severe cases of interstitial lung disease, including 3 deaths, all at the highest dose, which is no longer being developed. There is a randomized study that is ongoing that is comparing datopotamab deruxtecan or Dato-DXd to docetaxel in previously treated patients. There also was anti-tumor activity in a heavily pretreated population of patients who did have actionable genomic alterations with an objective response rate of 35% and a median duration of 9.5 months in that group. So the activity was similar to the population that did not have actionable genomic alterations that is being evaluated in the TROPION Lung 01 study. But for further development, of course, this group needs to be separated because the treatment algorithm, of course, is different for this population. And so there is an ongoing trial, the TROPION Lung 05 study, that is looking at patients with actionable genomic alterations and evaluating their outcome with Dato-DXd. There are additional studies that are being conducted looking at, for instance, different combinations, including combinations with immunotherapy along with Dato-DXd. Here you see the design for the phase 3 TROPION Lung 01 study that I mentioned. Again, patients are randomized. In this case, it is 1-to-1 who have advanced disease to Dato-DXd or docetaxel. Nearly 600 patients are anticipated to be enrolled, and there will be assessments for progression-free survival as well as overall survival.
Okay, thank you, Eddie. We'll move on to our next portion of our presentation, and we'll do some case discussions. And I think, Helena, this is your case.
Yeah, sure. So this, a patient of mine, a 60-year-old male, a 50-pack-year prior smoker who quit a month ago, presents with a new cough. He did get imaging workup that showed a CT scan with a 5-centimeter right upper lobe lung mass. He got a PET scan and an MRI for further to complete staging, and that showed hypermetabolic hilar and mediastinal lymph nodes, diffuse osseous metastases, as well as liver metastases. MRI brain did not show metastatic disease to the brain. He undergoes a liver biopsy with several cores sent to pathology. So what pathologic and molecular tests should be done? Perhaps, Pasi, do you want to say if this person saw you at Dana-Farber, what would be the reflexive test that would be sent up?
So thanks, Helena. So certainly reflexively, we would do a surgical pathology review, confirm that this is lung cancer, do IHC for things like TTF1. We would likely do PD-L1 staining reflexively on this individual as well. For us, molecular testing, which is standard of care, is an oncologist ordered test. But when this patient came to see us, we would order NGS on this individual as well. And with a combination of NGS and PD-L1 testing would help potentially guide subsequent treatment.
Eddie, any differences at UCLA, or is that pretty much the same?
No, we've worked to try and get a system where we can quickly, get patients evaluated. So ideally the oncologist doesn't have to order it. I think that's going to be a challenge we're going to have in the coming years, so that we're not seeing patients then having to wait for outcome. But again, the testing is really going to be the same here.
And then the final question I guess I would pose to both of you is, all of us discussed new antibody drug conjugates that are antibodies against specific proteins. We discussed HER2, HER3, TROP2, but of course there are others, MET ADCs, others in development. Do you foresee a future where the IHC testing for these different drugs will be reflexive and done on all of our patients? Or do you see the future really being more in unselected patients?
I'm happy to take that on first. I think for the time being, I don't know that we need to test for any of these particular biomarkers. I think, as you showed, and it was true for the HER2 mutants, and I believe the data is also true for TROP2, that there isn't a clear relationship between expression and efficacy at the moment. Now, at least by the current assays, that may change as we learn more nuanced ways of measuring these biomarkers. But for the moment, I don't see that. I don't know. Eddie, what do you think?
So the only thing that I would add that I think is a little bit interesting is I completely agree with the assessment. But one of the things that I think is very difficult is many practitioners are getting this data, maybe not for TROP2 or HER3, but for instance, there is one of the sort of central send-out pathology laboratories that many of the practitioners whose patients I see in second opinion use, that just routinely gets HER2 IHC across all tumor types. And so I think it's challenging for someone in community who's not managing lung cancer. I completely agree with you that to date, there's no data that would really say that this should guide our treatment decisions. But I think it's very hard for people who maybe will see, not as many lung cancer patients as we do, where this ends up being what we mostly see. And I do have concerns that people will be treating based on these before we really have any data to indicate that it's the right thing to do.
I agree.
Yeah, I think it's going to be a big challenge and more to come, because I think this ADC wave is definitely here to stay, and we'll be seeing more drugs.
Okay, let's discuss the second case. A 75-year-old female, never smoker, diagnosed with EGFR wild-type non-small cell lung cancer in November of 2019. She underwent NGS that had an STK11, ARID-A1 mutation, a TP53 mutation, as well as a HER2 mutation. Was treated with chemotherapy pembrolizumab successfully from December 2019 through February 2020, followed by pembrolizumab alone. Subsequently returned to clinic with progressive disease, as seen on this PET scan here on the right-hand side, and had a Garon done in June 2020 that was non-detectable or didn't have any sufficient information. So here, some questions again for discussion points. What would be the next line of treatment? Would it be standard of care, docetaxel or ramucirumab, or perhaps one of the ADCs that we discussed earlier today? Maybe I'll turn it to Helena first for her thoughts.
Sure. I mean, I think the standard of care would be, as noted on the slide, docetaxel and ramucirumab. Not all of our lung cancer patients are eligible for ramucirumab, but of course, if we have the option, the combination did have slightly greater efficacy. In terms of, of course, many different clinical trial options may be available to this patient, but focusing on the 3 ADCs that we discussed today, really the TROP2 ADC, the dato-deruxtecan, was the only one that was really assessed in, excuse me. I had forgotten about the HER2 alteration. So for this patient, you can see me thinking in real time. I think that the HER2 ADC would make the most sense. Of course, seeing the really impressive response rate and duration of response and PFS with that.
So maybe I'll pick up on that TROP2 ADC comment. Eddie, you showed the data on the actionable genomic alterations in the TROPION trial. Were there any HER2 mutant patients in there, do you recall?
So in that group, there were no HER2 mutation positive patients. And so I think that if one were looking for an ADC in this particular case, I think it is clear with no data that the trastuzumab deruxtecan would be an ADC that I would look at. I think that adotrastuzumab emtansine is still something that's listed for NCCN, although it was less effective, at least in breast cancer. By comparison, we don't have lung cancer data to indicate that. I think that to me, the bigger question is in the EGFR space, where there were a significant number of patients treated with Dato-DXd, as to what the relative enthusiasm for those two antibody drug conjugates is. But I think in this case, we just don't have the data for HER2 mutants in the Dato-DXd dataset.
Great. Let's move on here. Okay, so the patient ultimately ends up getting trastuzumab deruxtecan. She has a good response. However, about 2 months later, she feels well with no respiratory symptoms, but she comes back for restaging where she had the good response, and you see some ground glass opacities that's suspicious for ILD. So Helena, what do you do now?
Yeah, I mean, I think the comforting thing in this patient case is, of course, that the patient feels well. They're not hypoxic. They don't have dyspnea. So I feel good about that. Of course, if she was due to get treatment that day, I would hold treatment. And then we have a pretty good sort of algorithm where we send these patients pretty quickly to our pulmonary colleagues. I think people can go very quickly from asymptomatic to kind of really quite significantly symptomatic. And so, we would sort of discuss whether empiric steroids would be appropriate or just a hold of the drug, depending on the grade of the toxicity. And then really, of course, ruling out other sort of causes of ground glass opacities or infiltrates. But of course, my pretest probability for ILD or drug-induced pneumonitis would be high with trastuzumab deruxtecan.
Eddie, do you, any additional comments, or would you do anything different?
I wouldn't do anything different, but I think it's hard. And I'll just point that out, that it is, in many respects, when we're conducting clinical trials of agents like this, we're protected because the trial has a set of rules that says, if you see this, you have to do this. And clinical practice is not quite as straightforward. And ILD can be quite bad. And in fact, as we've seen in these studies, there have been patients who have died from them. But lung cancer is quite bad also. And I think these are going to be very difficult decisions. And I think we may, as we incorporate these agents into our treatment paradigm, have to brush up on our thoracic radiology and sort of try and make estimates of what what are the imaging findings that are going to tell us that we have to hold treatment today and have a patient assessed by pulmonary versus changes that we're comfortable with. I certainly don't think I'm at the point today to be making those sorts of assessments yet.
So okay, so you send her to the pulmonologist. She gets steroids, and you re-image her, and the scans are better. Do you re-challenge her? Getting to the practical question in real world, now what? She responded, she's better from the ILD, do you re-challenge her with this, or do we declare that she has to move on to some other therapy?
I think from my perspective, steroids would make me nervous if I really needed them. Now, the question that's going to come up is if somebody just put her on steroids, put the patient on steroids, if it wasn't needed, then I think it's a much more difficult thing. If somebody really developed sort of dyspnea that required steroids, I'd be reluctant to restart it, outside of sort of an emergency setting. I think we're gonna have much more difficult things, and one thing I probably sometimes want a little more control. If I thought it was not so bad, I might not send them to pulmonary for concern of getting started on steroids and being able to not assess whether or not the patient actually has been symptomatic from this, because I think these are going to be hard decisions. And that's why I say I think that we are going to have to be a little more expert over time. Or ideally, as these become more things that we're used to doing, we'll probably develop a rapport with our colleagues in pulmonary where they don't just reflexively start somebody on steroids and sort of take away our ability to assess whether this is a real clinical issue or not.
I was glad Eddie went first because I wasn't sure what I was going to say in terms of the answer. But yeah, I mean, I think that the distinction, if someone has hypoxia or significant symptoms, I actually probably would not be inclined to retry. I think the only situation I was thinking about it is if someone had, grade 1 asymptomatic, resolved, hopefully without intervention. I think that there would be and of course, if there were limited other options that we would go to, I think we will get, as Eddie said, into a position where we'll want to retry for some of those patients, because I think, in the real world, diagnosing ILD in a patient with lung cancer, prior smoker, is really challenging. And so I think we're going to see more and more of these gray cases.
And the only one additional thing I would add here, just from the experience of doing similar events to this in the early days of PD-1 inhibitors, and all of us agreeing wholeheartedly that we would never resume a PD-1 or PD-L1 inhibitor in somebody who had evidence of pneumonitis, only to then, a few months later, have someone who'd had a great response, had to stop for pneumonitis, and now is dying of lung cancer, and negotiating with them about whether or not to restart it. I think in practice these problems become more difficult, and I think that that over time we'll develop an experience as to what happens if you have to re-challenge. But I think it's much easier to say we would never do it in an event like this, and after having that experience with the PD-1 inhibitors, I anticipate we'll have that experience again, where patients who have done well do want another challenge, and I think it's going to be a decision we'll have to be making.
And I think just getting back to the diagnostic part too, we don't, access to expert pulmonologists who deal with this is going to be a limiting factor in the real world. And an ILD is essentially a diagnosis of exclusion too, so it's not, so you have to exclude other possibilities. So there definitely are challenges to this, and I think as we move along with these agents and many more to come, I think as you both point out, it's not so clear, and we'll need to balance the risks and benefits. Okay, so let's look at this. This is kind of a big picture of how we break down our targeted versus or oncogene addicted versus non-oncogene addicted therapies. We show here kind of where we would use the different ADCs, HER3 ADC, sort of post-OSI, post-chemotherapy, HER2 ADC post-chemotherapy, the TROP2 ADC, sort of, again, post-chemotherapy, post immune checkpoint inhibition. This is kind of the current landscape. Where do you think these agents are going to end up? Or do you think they will migrate into the frontline setting? We saw some trial designs potentially in the frontline setting, but Helena, what do you think for the ADCs?
I'm definitely interested in seeing these moved up. I think all of us are disappointed with our second line and beyond chemotherapy options. We're certainly not getting, great robust responses that are durable. So I think we definitely need more options. I think in particular in the EGFR mutant lung cancer space, I mean, now that we use osimertinib in the first line setting, we have no approved targeted therapies post osimertinib. So I think that is really a black box that needs to be filled with some new novel treatments. I'm really interested in the combination study with HER3-DXd with osimertinib. That is skipping kind of a line, so moving it up prior to platinum doublet chemotherapy. And I think most kind of interestingly as well is continuing the osimertinib. I know that you have data where perhaps that combination could be synergistic, and I think it gets to the point of a lot of us feeling very comfortable, especially with a patient that has brain metastases, and they are well controlled on osimertinib, being able to continue that osimertinib, but add in, a targeted agent like HER3-DXd to address systemic progression. That's really appealing. So I think that's a study that I'm looking out for, in particular in the EGFR space.
Great.
And just 2 days ago, I had a patient in the infusion center who, on carboplatin, pemetrexed, and pembrolizumab, who has a HER2 mutation. She's been doing quite well, and we've talked intermittently about the potential for we have a second line plan, and the exact question came up that she asked me: if you had the data today that you had at the time that you started treatment, would you still have started me on this, or would you have started me on the HER2 directed ADC? And in that case, it was very easy. We will be having the randomized trial, and so what I told her is that from my view, that I had equipoise for those two arms. I thought I don't know which is going to be a better approach, and I'm looking forward to enrolling patients and seeing the results on that study. But I do think it's a very fair and important question.
And where do you see the TROP2 ADC moving in the frontline setting, or do you see it in the frontline setting?
So I think it's a question. Everybody has sort of viewed one place to get one drug to get rid of, and it's not exactly clear that maybe the non-platinum chemo, and I don't know the answer to that. Obviously, there's a lot of development in the second line space. Obviously, patients who've progressed after chemoimmunotherapy is a significant unmet need, and certainly, if you saw even similar, even a slight decrement in the efficacy in the phase 3 study from Dato-DXd, one would anticipate that should be enough to be better than docetaxel, although we have to see. I think that we're revisiting a lot of our standard approaches, and I think we're going to learn what the right way to do things are in terms of what we would want to be replacing in that frontline setting. But I think it is certainly exciting.
I was just going to add to what Eddie said. I think we need sort of biomarkers. We're getting a lot, these new drugs that are in that, 25 to 30% response rate. You're not quite better than chemo IO. So whether it's finding kind of negative predictive biomarkers, patients that we know will not do well with chemo IO, and kind of looking at that population to move these kind of novel agents up, or on the flip side, I think I think that will help us in the future in terms of figuring out where to place these new drugs.
And we talked about ILD with these agents, but there are several trials ongoing with IO in these agents. You want to comment on that, either one of you?
Yeah, I mean, it's the hot thing, right? To combine everything, sort of if things work, let's put them together and see. I definitely am, concerned. I think that we have, we've combined agents with IO. When we think about like the osimertinib durvalumab data, where we weren't expecting kind of synergistic or additive toxicity, and we saw it. So I think, we'll just, and I'm sure the study investigators will be careful, but something like adding the HER2-DXd with chemo, with ICI, that would be something that would be pretty nerve-wracking for me. But yeah, I think we'll see what the data show.
Although the flip side of the experience with osimertinib and durvalumab would be the experience with chemoradiotherapy followed by durvalumab, which was one that would have been terrifying to me. I was not involved with that trial at the outset, but actually did much better than what we anticipated, and probably gets to the point that we still don't really know what we're doing with respect to this. That if you would have asked us, several years ago, whether or not it'd be easier to combine osimertinib with durvalumab or chemoradiotherapy, we would have all been absolutely confident in our answer, and we would have all been wrong. And so I think that it's going to be an exciting time, and maybe sometimes a scary time in clinical trials, to try and figure out what the appropriate placement of these are, and what's going to turn out to be safe and what isn't.
And that's why we do the trials, to figure out both the efficacy as well as what's not safe to give together. Okay, so one quick last case. Eddie, was this your case?
Yeah, and it really gets at exactly the points that I was making before. So there's a 66-year-old man, locally advanced disease, had chemoradiotherapy, which actually had to be stopped for radiation pneumonitis, required steroids. But after a couple months, the steroids were able to be tapered off, and the patient was initiated on durvalumab, which is a sort of a scary proposition, but presumably the practitioner is sort of hoping that the toxicity would not be necessarily exacerbated by durvalumab. And the toxicity wasn't exacerbated by durvalumab, but there was no efficacy, in the sense that the patient progressed and has now, in rapid succession, progressed through chemoradiotherapy followed by immunotherapy. The patient had a known HER2 mutation, and so now getting away from the question of IO combined with one of these agents, do you feel comfortable knowing that this patient had radiation pneumonitis, and do you think that would be a risk factor for the toxicity of ILD?
Well, I think I would worry about it a little bit. Most of the patients that had radiation pneumonitis were also excluded from the trials. So we don't really have data on any kind of lung injury and how well or how not well it predicts for subsequent pneumonitis from an ADC. But one would certainly worry about it. But I think, to your point that you made earlier, lung cancer is bad as well. And so I think you have to balance out the pros and cons here.
I totally agree. I don't have too much more to add. I guess I'd want a little bit more details of, like, did they get weekly carbotaxol with chemotherapy, and could we try just like platinum kind of systemic dose chemotherapy? I might use that as a hedge, but I agree. I think it's not that the HER2 DXD is off the table. It's just kind of wanting things to cool off a little bit before maybe I'd feel comfortable testing the waters.
And I think there was an additional question related to this case, and that was CNS penetrance of ADCs. Helena, thoughts?
Yeah, I mean, I think that is kind of coming into sort of our knowledge about this type of molecule. ADCs, just like antibodies, are bulkier. And of course, there is some concern about blood-brain barrier penetration. I think that the key to this is we just have to look at the data. I think that when things work, they tend to work, systemically and in the CNS. And so I would just encourage, as these studies move forward, of course, all studies really need to have good CNS efficacy endpoints built into the study. So we have that data, and we can sort of make those decisions about, how we would want to use these drugs for our patients with brain mets.
Eddie, any experience from the TROP2 world about CNS activity?
No, anecdotally, we've had some people whose brain, had brain metastases that improved. Always a little hard to know without rigorous evaluation whether that could be secondary to prior therapy, but makes me hopeful. But certainly, these are large molecules.
Absolutely. Okay, well, I want to thank my colleagues, Drs. Garon and you, for a wonderful discussion today, and thank all of you for attending. Please visit us at peerreview.com/ADC2022. Complete and submit your post-test and evaluation for credit. Download the slides and practice aids. Watch the replay of this event in the next 24 hours, to be followed by the online activity in the coming weeks. And thank you again for joining us today.